So we'll be focusing on that nuanced space of intermediate risk bladder cancer, throughout the course of this episode. So let's just start off by, having you walk me through how you explain risk stratification to patients who are diagnosed in this intermediate risk space.
Yeah, so it's a great question. I think our guidelines, the various guidelines make it a little bit confusing because it's not very clear which patients really fit into the intermediate risk group. There's lots of nuances depending on which guidelines you're looking at to help stratify which patients really qualify for that group. In my practice, patients that have a small, solitary, low-grade tumor, less than 3 centimeters, they are low-risk patients. Any patient that has any component of high-grade disease, and this differs some from the guidelines, I consider high risk. And I think many of us that are practicing urologic oncologists practice that way. And so then for the intermediate risk group, it's really all these patients that have multifocal, recurrent, very large, low-grade TA tumors. It still is quite a heterogeneous group, but I think different than some of the guidelines, including the AUA guidelines and the newest versions of the EAU guidelines, which do incorporate some small high-grade tumors into that intermediate risk group. When I counsel patients and treat patients, if they have a high-grade component, they're treated as high risk.
Yeah, and I think that's right. I think a lot of times we tend to group patients into that high-risk category just to be on the safe side. I'm curious, though, do you feel that we're a little too aggressive in that regard? Part of this is challenged by the fact that there's not a lot of current options for intermediate risk, and it, in the setting of a BCG shortage, it gets a little tricky. But, I kind of get that sense that sometimes we're overly aggressive. Tell me your thoughts on that.
For sure, especially for patients with low risk and intermediate risk disease, these patients that have low grade TA tumors, I think there's a lot of room for us to de-intensify the treatment, the surveillance. Many of these patients are in their 80s, 90s with a lot of other competing comorbidities. And for a patient that has an occasional low grade TA or a few small low grade TA tumors, it's exceedingly unlikely that that's going to shorten their lifespan in any way. And so I think there's a lot of room for moving towards surveillance for some of these patients, for considering clinic fulguration for some of these patients. And some of it's also driven by patient concern and anxiety. So not to say that none of these patients shouldn't be getting treated, but I definitely think there's room for us to be doing less for some of these patients.
Yeah. What specific factors influence whether you pursue intravesical therapy or, like you mentioned, manage those patients conservatively?
Yeah. So I think there's a number of risk factors, and I think the IBCG has done a nice job of kind of describing some of the risk factors for patients that are going to have increased risk of recurrence and progression. And so patients with multiple of those risk factors are more likely to offer some sort of intravesical therapy to. Patients that have multifocal tumors, frequent recurrences, multiple within a year, large tumors. So those would all be reasons that I'd be more likely to recommend some sort of intravesical therapy. Some of this also, like I said, is really needs to be more patient-centered. So the 90-year-old lady who has 3 small, low-grade appearing tumors that are a couple millimeters in size, though she might have multiple risk factors because she has multiple tumors, having her come once a week to get intravesical gemcitabine when she's also dealing with a recent hip fracture and everything else in the transport. I don't think we're really moving the needle on, certainly not moving the needle in survival, and probably moving the needle in the wrong direction in terms of quality of life.
Yeah, definitely. So along those lines, you mentioned gemcitabine. What intravesical therapies do you currently consider for intermediate risk patients who may be, those types of patients that have factors that would push you to doing something?
Yeah, so for most of my intermediate risk patients that have low-grade disease, intravesical gemcitabine is really my first-line treatment option. Occasionally in patients with multiple different risk factors, considering BCG, but typically I would do gemcitabine first and reserve BCG for patients that are refractory to that. I also think it's a great space to consider enrolling patients on clinical trials, especially since this is not a disease that's likely to shorten their lifespan at all. And so any new agents that can kind of prolong that time between recurrences would be wonderful. So we have the Pivot-006 trial open here with cretostimogene. And so I also will enroll patients on that trial currently, but typically gemcitabine are talking to them about a trial.
What other new agents, on the horizon excite you? What are things that you're paying attention to in this space?
Yeah, so I mean, I think it's, in general, a super exciting time to be in bladder cancer. I think the TAR devices are really exciting. There's obviously the TAR-210, which is erdafitinib for patients with FGFR mutations. TAR-200 with gemcitabine obviously has mostly been studied in the high-risk space, but I think for this patient population could potentially be like really amazing, especially with that prolonged release and the opportunity to give some chemoablation to these really small 1 or 2 millimeter tumors that we see. As I mentioned before, cretostimogene, so looking at the new oncolytic adenoviruses and where they fit into this treatment paradigm. UGN 102 is another, reverse thermal mitomycin, again offering chemoablation. So kind of moving away from having to take patients to the OR every single time they have a recurrence for a TUR, and what treatments can we be giving in clinic to minimize the number of times we need to be taking these patients to the operating room.
Yeah, definitely. And you alluded to this earlier. The thing I think about in that space with chemoablative therapy is avoiding anesthesia in patients who are high risk. You mentioned the older patients, the patients who may have concurrent comorbidities, the elderly patient with the hip fractures, all of that. So I agree with you. Super, super exciting space to be in.